So that is the reason we thought of having again starting with the webinars. So today we have three speakers. We have another webinar coming up on 17th of July. And third, we will be celebrating Doctor's Day program. Again, there are three lectures followed by a Doctor's Day program. Of course, there will be a credit point for the lecture program also. There is one credit point. And so I request all of you, you do attend that Doctor's Day celebration. And we are going to felicitate three important giants in the field of medicine. One is Dr. Mohan Joshi, who is the Dean of Sion Hospital. One is Dr. Pankaj Parekh, who is a well-known pediatrician from South Mumbai. And third is Dr. Nitin Mokar, who is a plastic and reconstructive surgeon and has done a lot of social work in this field. Also, we have another award to be given on that day, and that is the HM Shah Award. And this time that award is given to Dr. Shanbag, Dr. H.G. Shanbag or Dr. Sridhar Shanbag, who is from our branch. So I request all of you to be present for that felicitation program. Of course, there will be a small gift for all those who attend that program, which should be given right in the beginning only. So I request you to be present. After that program, again on 17th of July, we have a webinar. We have got 8 lectures on that particular day. So without wasting much of time, I request Dr. Kajal to proceed with the program.
To start the webinar, I'll request our convener, Dr. Sarita Devi, to kindly introduce our first speaker, Dr. Ruchira Mishra.
Good morning, friends. Dr. Ruchira Mishra is a senior consultant in the Department of Pediatric Hemato-Oncology and BMT at SRCC Children's Hospital. She completed her MBBS from Kanpur University with distinction in biochemistry. She did DCH from LLRM Medical College, Meerut, followed by DNB Pediatrics from Bombay Hospital Institute of Medical Sciences. Dr. Mishra then pursued pediatric hematology oncology and BMT training in Australia and worked in Brisbane, Melbourne, and Sydney. She took further training at Children's Hospital Westmead in Sydney in pediatric oncology and earned a specialization in BMT. Dr. Mishra was also involved in setting up the pediatric transplant program at Medanta, the Medicity Hospital at Gurgaon, and Rainbow Children's Hospital, New Delhi. Her areas of expertise include BMT for relapsed malignancies, for thalassemia, and for inborn error of metabolism. Dr. Mishra had authored a number of articles in peer-reviewed journals and textbooks and has been a faculty at numerous conferences. Today, she will speak on indication for bone marrow transplant in pediatric. Welcome, Dr. Mishra.
Thank you so much, Dr. Sarita, for that kind introduction. I am so thankful for the webinar series to have been restarted because I'm just down with cough and cold, and so I'll beg your pardon if I have to intervene in the middle for a drink or so. But we met two weeks ago on the 19th of June when we talked about the importance of a CBC, when we were discussing how important it is to read the full CBC in totality rather than just looking at a few values like an HPTLC or a platelet, and we could get a lot of answers out of that. I'm kind of adding on to that series by saying in pediatrics, a lot of diseases are now amenable to cure with bone marrow transplantations. And we'll discuss about what are those indications for bone marrow transplant, which are the cases that should be referred for bone marrow transplant, and also then how does the actual process take place, because we as transplanters need your help as being the primary caretakers for the patients. All our patients have a lot of trust in you all, And even though we, the transplanters, tell them something that this is important for you, this is how we would give the treatment, they will always come back to you to kind of seek corroboration of what we have said and to take your guidance and your help in deciding whether they should actually proceed for a transplant or not. There are a few myths around transplant. A lot of people, especially the patients and their families, don't know a lot about transplants, especially pediatric transplants. And therefore, their primary physician becomes the most important person for them to go back to and check and then take on their treatment forward from there. So this is actually a call out for help. It's actually a call out to say that please do support us in our program for transplants. And these are the indications where children would need transplants. And this is the basic process how transplants are going to be done, so that they get a feedback or they get a corroboration of what we are saying to them as well. So what basically are bone marrow transplants? So when you read up literature, you will find, if you're looking at scientific journals, the term BMT is kind of going out of vogue right now. And there's a term called HSCT that is more in vogue, that is more in scientific literature, or a term called SCT or stem cell therapy that is coming in as well. So is it actually different? Is BMT or bone marrow transplants different from HSCT or from stem cell therapy? So when the transplant started, or when bone marrow transplant started, we knew that the cell that we were trying to catch was the cell originating from the bone marrow itself. And that is why it was called a bone marrow transplant, because we were using the cells that were present in the bone marrow of the donor and trying to replace the bone marrow of the patient as well. So the term was bone marrow transplant, which is actually what was done previously. Now we've become a bit more scientific, and we've started saying that it is actually the hemopoietic stem cells, the cells that are responsible for the blood system, the hemopoietic system of the body, that we are trying to transplant and change. And therefore, the more scientific term is an HSCT. So that is why scientific journals will now not use the term BMT, they will use the term HSCT. However, whenever you're going in for approvals, we still get approvals rejected if I use the term HSCT. People giving approvals or the NGOs giving approvals will still give approvals only if I mention the term bone marrow transplant, because for them, SCT or stem cell therapy is something that is not done right now. So stem cell therapy could be any stem cells that could be used anywhere in the body. You've heard a lot about stem cells being used for spinal tumors, stem cells being used to cure Duchenne's muscular dystrophy or for cerebral palsy. So we know that these indications are actually right now on a trial basis. They've actually not proved to be very meritorious right now. So a lot of people will not give approvals for that. But we know that bone marrow transplants or HSCT is a standard treatment that is available for a lot of diseases. And therefore, those treatments should be approved and should be put forward. So I would say that BMT and HSCT is just the same thing. They're not different. But in common parlance, we use the term BMT, whereas in scientific journals, the term HSCT is more common. Stem cell therapy is a very broad term which encompasses a lot of other therapies as well. And that is something that we're trying to avoid right now. So why the term bone marrow transplant? Well, you know that the stem cells of the body, the hemopoietic stem cells, have the capacity to differentiate and to mature into different parts of the cells of the hemopoietic system. They could actually mature into the red blood cells. They could then go on and mature into the white blood cells also, or also form the platelets of the body. So this one stem cell can differentiate into different cell lines. Just like when we were kids and doing our MBBS, we didn't know which way to go. We could either become gastroenterologists or neurologists or even an anesthesiologist. The stem cell has the capacity to do different things. It just needs to be programmed and told that this is the direction it needs to move into. And we're going to take advantage of that itself to cure disorders which are pertaining to any of these three cell lines, be it the red cell disorders, be it white cell disorders, or be it platelet disorders as well. So what are the What is the property of a stem cell? Why do you want to use that stem cell? Stem cells are those cells that form the blood and the immune cells. So please note that it's not just the blood cells. Our immune system is also originating from the hemopoietic system. And so we would use them also. They have 4 capacities or 4 actions, that they can renew themselves. They can differentiate into different cells that we have just talked about. They can mobilize out into circulation and even out of circulation, so they can go to bones and other organs of the body. And best of all, they undergo apoptosis. So they do not have an uncontrolled growth and they do not result in cancer. This is something that we are finding, because when we're looking at gene therapy, there are some reports to say that when you're doing gene therapy, there are reports that they're transforming into leukemia cells, which means that there is an uncontrolled growth happening over there. And this is something we don't see in the hemopoietic stem cell itself. So we know that these cells can renew, they will form into mature into different cells, but then they will eventually undergo apoptosis and will die off. But if we have a renewed system, then they will continue to form the hemopoietic cells for the body. So what are the indications that we can do a bone marrow transplant in pediatrics for? And this is the crux. This is probably the most important slide of my presentation. When we talk about pediatric leukemias or pediatric cancers, often we say that pediatric cancers are very, very curable, which means that either by using chemotherapy, radiation therapy, surgery, or a combination of the two, we would generally be able to cure about 80 to 85% of our patients. And in most cases, bone marrow transplant does not form the first line of therapy for these patients. So in pediatrics, bone marrow transplant, except for a very few disorders, is generally reserved as second line therapy. Only when the child relapses or we find that the child is not responding to the first line of therapy do we then think that we will offer a bone marrow transplant to our patient. Also, bone marrow transplant is always a consolidation therapy for our leukemias, which means that these children will first have to go into remission, which means the disease has to be controlled. Only then will we offer them a transplant as a mop-up or a consolidation therapy of their treatment. So if somebody has active disease, we will not be able to offer treatment with a bone marrow transplant to these patients. So what are the indications for malignant conditions? When you have acute lymphoblastic leukemia in second or further CR. So if you've relapsed first, second, third, or multiple times, only then will we offer you a transplant. If you have a high-risk disease, that is patients who have high-risk disease, that is a 922 or a 411 translocation, or a T-cell ALL, which has had a poor prednisolone response. Now because we use MRD as a diagnostic criteria, if you have high MRD, then yes, we will be offering you a transplant for those patients. High risk AML in the first remission, or else if you have relapsed, only then would we offer you a transplant. CML in blast crisis, a high risk Ewing sarcoma or a relapsed Ewing sarcoma, and again relapsed Hodgkin's disease. Stage 4 neuroblastoma is one disease where we offer bone marrow transplants upfront. It's part of the treatment that we give to all our children, and that's an autologous bone marrow transplant that we offer these children, because we know that it's a very, very aggressive disease and we are hitting out with almost everything that we have to offer. For a neuroblastoma, we will be treating them with chemotherapy, with surgery, with radiation, and even a bone marrow transplant. And in spite of doing all the best we can, a high-risk neuroblastoma like a stage 4 or an NMIG amplified, the cure rate still, in spite of doing all this, is only about 30 to 40%. So that is why we're giving it all the best we can. And the intention of giving the bone marrow transplant in a neuroblastoma is the ability to be able to give high-dose chemotherapy for these patients. Also for myelodysplastic syndromes, we will use it because we know that often these myelodysplastic syndromes will then change into AMLs, and then they're high-risk AMLs, so they will need transplants for in those conditions. But on the right-hand side, if you notice the list, that list is even longer, but all these are non-malignant conditions. So pediatric bone marrow transplants often act as a cure for all our non-malignant conditions arising from any of the 3 cell lines that we talked about earlier. So if you had a red blood cell disorder, we would be looking at doing a bone marrow transplant to cure it because we knew that the stem cell itself was defective. And this would be diseases like thalassemia, sickle cell anemia, severe aplastic anemia, be it acquired or be it a Fanconi anemia. It could also be diseases like pure red cell aplasia, which is not responding to steroids, or even a Diamond-Blackfan anemia would respond to a bone marrow transplant itself. You could have white cell disorders that will be treated by bone marrow transplant, and these could be CGDs, chronic granulomatous disease. You could have Costman syndrome. You could have SCID. We actually have a SCID in our hospital right now that we're waiting to transplant right now, or other immunodeficiencies like Pomens, or an immunodeficiency with a hyper-M, or a leukocyte addition deficiency as well. You could also use these to transplant platelet disorders. So be it a Viscott-Aldrich syndrome, be a congenital amegakaryocytic thrombocytopenia, or even a refractory HLH. These would be conditions that would be treated by a bone marrow transplant. And in all these conditions, BMTs are curative in this. Apart from these, the common standard 3 lines that we talked about, there are some disorders which don't stand out as being a hematopoietic stem cell disorder, but are actually hematopoietic disorders as well, be it lysosomal deficiencies, which we see in terms of disorders of your metabolic disorders, so be it a Hurler's or a Hunter's disorder, the mucopolysaccharidosis, the paroxysmal diseases. These can be cured by transplants as well. Some neurological disorders like X-linked leukodystrophy or MLD can also be treated by bone marrow transplants, provided that the neurological deficit is not severe enough to say that we're not going to be able to improve. So when we are talking about neurological disorders, what we actually say is that if the neurological deficit has already set in, we will not be able to reverse that itself. What we will do is be able to prevent further damage from happening, because whatever damage has happened, we will then replace the enzyme from then on. So what damage has been done, we cannot replace that, but we will try and prevent further damage from happening. So the best time to transplant anybody with a potential neurological deficit coming in would be right at the onset, when you diagnose very quickly, or if you know that there is a family history and the child is still asymptomatic at that time, because that's when the maximum benefit is what you will gain out of it. To transplant somebody who's already lost his vision and like an MLD, is bed bound, has lost his hearing, has lost bladder bowel function, doesn't actually serve the purpose of a transplant, because what we want to improve is both their quality of life and their life expectancy as well. So we've done diseases like Krabbe's disease that we've transplanted when we know that the child presented only with vision loss without any other neurological dysfunction. And when the transplant was done, she still hasn't regained her vision loss, but she's still active, mobile, she's going to school, and she's doing all daily routine activities without anybody else's help. And that's because the transplant is supplying the enzyme for her. So when you look at these, remember that this is because the enzyme replacement is happening by an inherent mechanism now. We could also use it for diseases like malignant osteoporosis. Now again, osteoporosis is a bone disorder, but people function, why would a hematopoietic cell system work for this? And the reason for that is that the osteoclasts are actually myeloid in origin. So they will, once you transplant them, the myeloid series will then transform into osteoclasts, and they will kind of take over that defective process and normalize it for you. So these are conditions that we can transplant with. And we should be actually aware of all of these, because only when we remember them can we then refer for a transplant quickly to them. So if I have this case that I can present to you, a 7-year-old boy presenting with a history of pallor and failure to thrive since 6 months of age, has been needing regular transfusions for 6 years, has hepatosplenomegaly, and has a raised HbF. Everyone can give me the diagnosis. This is a Thal major patient. So why would we transplant a Thal major patient? we know that the standard treatment offered to them is regular blood transfusions and then chelation therapy. But we also know that with time, they will land up with other disorders, that morbidity increases. They tend to develop diabetes, they tend to develop osteoporosis, then they develop refractory non-healing ulcers and a lot of other problems as well. And if they're not well chelated, they will develop liver fibrosis and things like that. So we generally classify our patients into 3 groups, that is based on class 1, class 2, and class 3, based on the chelation, the hepatomegaly, and the liver fibrosis. And if based on that, if we've learned that if we transplant them early, then that is what their survival looks like. A class 1 transplanted will have a survival benefit of about 90%. That means that they have the chance to be able to be a transfusion independent. 90% of these patients will be transfusion independent and will not have problems of iron overload of them. With class 2, this number goes down to about 80%. And with class 3, you notice that this goes down to about 60%. So it is obviously better to transplant them as early as possible. With adults, we know that this overall survival or transplant-free state is only between 63 to 67%. So there is an obvious benefit to transplant our thalassemics as early as possible. Now, generally, we say that we would like to transplant them between 2 to 10 years of age. That's the ideal time to transplant them. And the reason being that the child is able to vocalize and tell you what's happening with him, because transplants are not a very easy process. Sorry. Also, the parents get some time to generate funds for a transplant, because again, transplants are not easy and they're not very cheap processes as well. So this is a second patient, a second case scenario that I'm presenting to you. A 5-year-old female child presents with a VSD closure. But the PAC showed that she was short-statured, she had defects in her digits, she had defects in her teeth, she had pancytopenia on the CBC with a platelet count that was only 30,000, but she also had pancytopenia. So both hemoglobin was low, white cell count was low, and the platelets were low. What was the diagnosis? This was actually a case of Fanconi's anemia. And this is a picture of the bone marrow aspirate to show that this was a hypocellular marrow. So severe aplastic anemia or very severe aplastic anemia will generally benefit from a bone marrow transplant. And the algorithm goes to show that if you have a matched sibling donor, then you should be offering them a transplant up front. If you don't have a matched sibling donor, then you can either think about offering them ISCT, which is immunosuppressive therapy, versus you can offer them a bone marrow transplant. We know that in pediatrics, we often find that ISCT does not work. And therefore, we transplanters are actually advocating that they should be offered transplants upfront as well, even in children who are less than, who are not an acquired, not of familial aplastic anemia. Then comes primary immunodeficiencies. Primary immunodeficiency disorders are a disorder category which is not very well recognized in our system. And often they are picked up very, very late. So there is this algorithm to say that if you have had any of these criteria, then you should be thinking about PIDs. You could go to the JM Morgan site and you can kind of take these out for you, but always keep an eye out and be aware that PIDs could be presenting to you without being very, very obvious. So this is something that we need to look out for and work for them as well. So how do we actually transplant our patients? The first basic criteria that we look for is HLA typing. HLAs are proteins that are found on your blood system. And this HLA typing is the kind of match that we are looking for. So we're not looking for a blood group match, we're looking for an HLA match. And we're looking at this HLA match on both class 1 and class 2 proteins. So we're looking at A, B, C, DR, and DQ points, DQB1 points. DPB1 is now coming in as well. So if you get a DPB1 match as well, you are you've got a very good match there. But if you don't have one, even if you match on these 5 different loci, then we call it a match. Now remember that one gene comes from the mother, one gene comes from the father. So even though we're looking at these 5 points, we're actually matching at 10 points. So that is how we do the matching for these patients. How do we do the transplant? There are different kinds of transplants that we can offer. The best that we talk about is a matched sibling donor transplant, which means that your brother or sister is a match for you. It's a full match, 10 by 10 match for you, or a 6 by 6 match in the local parlance. This is the gold standard for treatment. We know that there will be a rapid immune reconstitution happening, but however, the cons is that they're not generally available. Only 1 out of 4 children is likely to be a match in the family. So the probability of finding a match is only about 25%. And as we're moving to single families or one child families, this will even become more and more difficult for us. The second would be unrelated bone marrow transplants, where we're looking for a 10 by 10 match outside the family. So international registries or national registries where we look for donors. Again, a 10 by 10 match is as good as a family match. And this then becomes the way we can offer a transplant. Only the problem is that about 50% of our patients will find a match here. And the time taken to get the cells is quite long. So that's the problem over there. If we wanted to rapidly take for a transplant, it becomes a problem. Then comes the unrelated cord blood programs. So unrelated cord blood, and everyone knows about cord blood banking. Availability is a very good pro for it, because we know that 95% of the time these cord units are already typed. You know what cell dose you're getting and you have a type, so they can be quickly transported and given to you. So it takes very little time to take up for transplant. They do not cause GVHD as much. There is no risk to the donor per se. The cons is the lower number. We cannot use it again. There are very small doses available for us. So if you have a big child or a big weight, then it's very difficult to use these units. And it takes a little longer for these cells to engraft. So the hospitalization is longer for us. Now, please remember, with cord blood banking, this is an unrelated cord. It's not the cord that is used stored for the patient itself. If you're talking about the patient themselves, their stem cells are defective. Therefore, this cord unit is also defective. So it's of no use to the patient per se. So all private cord blood banks that actually promote preservation of the cord units for the patient themselves or for the baby themselves are actually a scam. They will not be using it at all. You will not be getting to any benefit out of it. The benefit comes only when it is donated for somebody else's use. About 75% of our patients will get a donor by this method, but another 25% may not actually find a donor at all. And that's when haploidentical transplants come in. With parents always ready to do everything for their child, we know that the haploidentical transplants with one of the parents becoming a donor is a very good option available for us. And that's the way we would like to proceed as well. So whenever you decided that a patient needs a transplant, we know that we will always find a donor no matter what. So as I said, that this is the way we will go forward. How do we take the cells? There are 3 ways of taking the cells. We've already talked about the cord blood unit, which everyone is aware of. Most of the times we're doing a PBSC collection. So this is just like a platelet apheresis, like a donor would do. So the blood goes out from one system, gets apheresed in the machine. The cells are collected out and the remaining blood is returned back to the patient. So there is no danger to the donor in any form while doing a PBSC donation for them. The third way that we can do a collection is by doing a bone marrow harvest, which means that from both the iliac crest, we will take out the bone marrow and we will collect the amount that we need to do. For this, the patient needs to be under a general anesthetic. So there are anesthesia risks involved in this. Apart from that, again, there is no risk to the donor as well. So for all our primary physicians, if the parents come back to you asking that my sibling is a match for my patient, should I actually undergo the transplant? Will it be a risk to the donor? There is a one-line statement. There is no risk to the donor at all for giving the cells. The chances that you will actually save your brother or sister's life by doing this procedure. So please go ahead and promote this. When we do the transplant, we will first make sure that the patient is actually ready to do the transplant. So he's in a fit condition to bear the chemotherapy and the effects of the chemotherapy. And the disease is under remission if this is a malignant condition. Then we offer them conditioning chemotherapy. So even if it is a non-malignant condition like a thalassemia, they will get chemotherapy with the intention that we will destroy their existing bone marrow and make place for the new marrow to come in. And this could in some cases also involve radiation. We infuse the new stem cells like a blood transfusion. There is no surgery involved in a bone marrow transplant. So this is a physician's transplant that we are doing. And then we wait for recovery from the transplant. So we monitor for complications and all that. The expertise in a bone marrow transplant lies in deciding what conditioning we need to offer them. And there are 3 different kinds of conditioning that we use. That is myeloablative, reduced intensity, and reduced toxicity regimens. And depending on what will benefit the patient, we will choose one of these methods. So the myeloablative chemotherapies are ones which will completely destroy your marrow, so make you very immunosuppressed for a very long time, versus reduced intensity, which needs some amount of immunosuppression, but not complete, and the non-myeloablative ones, which are not very toxic to the patient, and therefore they're not very distressed or not very serious during the transplant. But depending on the disease process and the clinical condition of the patient, we will decide this. Now, ATG is one of the biggest things that we are considering while we're doing transplants. And the reason being that the ATG destroys the lymphocytes of this patient. So we know that if we don't give enough ATG, we will not get good engraftment. However, if we give too much ATG to a patient, we sometimes land up with increased infection because they're prolonged immunosuppressed for a very long time. So ATG forms one of the biggest medications that we offer these patients, and this is one way of T-cell depletion that we offer the patients in vivo for the patients, because we know that those lymphocytes, if the patient's lymphocytes remain in the system, they will lead to rejection. However, profound T-cell depletion will actually lead to infections for our patients. Now, we've noticed that with ATG, the HLA-matched siblings that we were transplanting for severe aplastic anemia, when we didn't give them ATG, the relapse rates or their rejection rates were far higher than they were when we were giving ATG, be it whether it was for bone marrow grafts or be it for peripheral blood grafts. And therefore, ATG becomes one of the important factors. Though it is not a chemo medication, it is still a very important part of our conditioning regimen now for most of our disorders. We also look into different diseases or different infections that are happening during the transplant, and that is why transplants become very important, that you need to keep the patient very safe during the transplant, and almost up to 1 year, we are looking to keep these patients under close monitoring, because we know that they will get some infection or some problems later on. But however, if 1 year is passed, then we know that these children will now recover well, and they will now be able to get their own immune system, which will help them to find disorders as well. So if you've survived 1 year post-transplant, we know that you will do well for a longer time. These are some of the complications that children do undergo during transplant, but the numbers are gradually less, and we work with this. We know that bigger the challenge, the bigger the opportunity. And this is where we are asking for your help, because we also know that if you guide us, if you guide the patients well, we know that we will be able to cure a lot of these children without them having a lot of complications, because they will present earlier to us. Yes, transplants are expensive. They are not easy to do, and they're a costly affair. However, I've noticed that Mumbai, there are a lot of NGOs which are willing to give us a very big helping hand as well. So we know that we get a lot of help from NGOs. The patient doesn't have to bear the full burden of the transplant themselves. And we can always get help if we've decided that this kid needs transplants. So this is how a donor gives. So on the left-hand side, you can see that they're donating blood, and a very similar process of peripheral blood stem cell harvest being done on the right-hand side. So not very different for the patient, for the donor at all. I will stop over here. Thank you so much for your attention. I'm very happy. If there are any questions, I'll be more than happy to take them. So I can answer them.
Thank you, Dr. Ruchira Mishra, for such an informative lecture. Any questions from the panelists? No, they are not the questions.
Like,
Dr. Ruchi.
madam, how many days you require hospitalization for this transplant patients post-transplant?
So, ma'am, generally we will say that we will need them to be in hospital for the first month of the transplant. However, they will need to be under intensive monitoring for at least 3 months post-transplant. So they keep coming in for OPD visits, and they will come in for their tests and everything for the first 3 months. After 3 months, if they're not from within Mumbai, we will let them go back to their city. The actual hospitalization is about a month.
Okay.
Thank you, Dr. Ruchira Mishra. Now, going on to the second speaker, I'll request our Assistant Secretary, Dr. Kashyap Dakshini, to kindly introduce Dr. Altamas Sheikh.
Good morning, friends. Dr. Altamas Sheikh is a consultant endocrinologist, diabetologist, and metabolic specialist at Saifi Hospital, Masina Hospital, Raija Hospital, Prince Ali Khan Infertility Clinic, and KJSMC in Mumbai. He's a part of the scientific committee of ISBMR, FredCon. He's done various thyroid conferences, and was also part of the ESICON 2019. He's a joint treasurer of the Maharashtra Endocrine Society. And he's won various, he's been a speaker of various national and international conferences, and has co-authored in India and abroad in various peer-reviewed journals and textbooks and chapters. Today, he will speak on rescripting the guidelines for CKD with dapagliflozin. Thank you. Over to Dr. Sheikh.
Can I speak from here? I'm seeing very
Yeah.
Okay. Good morning, everybody. One of you will have to mute. Good morning, everybody. I think it's my big fortune that today, actually, I have come to IMA office, and I'm with Dr. Awad, Dr. Ahuja, and the whole IMA body over here. And we are going to talk about rescripting the diabetes prescription. It's going to be a very, very practical and an actionable talk. And I would suggest either you would please write your answers that we ask in between as we move ahead, so that it's a properly interactive session. What do we do when we see a patient like this who has come with breathlessness, and we think that the patient is just trying to mimic or give a gimmick, or the patient is just tired? The answer is, earlier, when there were no lack of evidences or lack of testing that we had, we really didn't think about that. Could it be really failure of the heart itself which is causing this kind of breathlessness to some people? But however, with advent of tests like BNP, pro-BNP, and evidences that these can be treated, we have seen, apart from atherosclerosis and apart from the CV complications of CAD, heart failure as one of the big elephants in the room. And that's where, if you see across the altitude trial or the IDNT or the renal, we see that yes, HF is been one of the important prongs, and we have updated and changing guidelines to treat diabetes, kidney disease, and heart failure as one of the important part of management. And that's where we take this into picture. If you look at this red 7.7, the mortality rate of people dying not because of diabetes and kidney disease is very low. And if there is diabetes and no kidney disease, it increases. However, if you compare this 11 with 7.7 to all cancers, you see suddenly that's what is the fear of dying, death because of cancer. But if you just add kidney damage in the form of increased creatinine or reduced EGFR and increase in albuminuria, if you combine these two, now look at the yellow bar, it makes it nearly 55% chance of excess dying, which is just more than actually your all cancers taken together. And this is what we have to discuss today, that how can we prevent these kind of complications? How can we prevent these kind of deaths excessively and reduce and give them a good quality of life from here? In India, if you see overall, Asian Indians, we have nearly 5,000 dialysis center which cater to more than 2 lakh patients on dialysis, and nearly 17% prevalence with adult population. If you look at CKD by stage, we have a huge population in stage 5. If you see here, this in the turquoise blue color, stage 5. And if you see CKD with diabetes by stage, again, we have a huge stage 4 and stage 5. That's nearly 70% of CKD people of diabetes are in this particular stage. And that really makes us think that we should be preventing this kind of a disease. So how do you do that? Importantly, I've been talking in my sessions always, how do you calculate eGFR? Some fastest finger first can just write the answer in the chat box. How do you do that? How do you calculate eGFR? Which app you are using? If you look at this particular graph, G1 to G5, and here A1, A2 to A3, this is albuminurias. We read the upper one as the easiest one. Less than 30 is normal, 30 to 300 is A2 stage, and more than 300 is the A3 stage. If you look at G1 to G5, we generally see a lot of patients here at G3A, G3B, G4, and of course with G5, the patient goes to nephrologist. Question of interest, what is nephrologist called in Hindi? Anybody? Write your answer. We'll try to give you some gifts. Okay. Now, if you look at classification of CKD, you must also consider the etiology of this disease, which could be either diabetes, cancer, hypertension, or polycystic kidney disease, or a primary disease. We usually see a lot of patients here in the red one. I'm going to show you next when I click on this slide here. This is where the increasing risk comes with decreasing eGFR and increasing risk with increasing A3 or increasing proteinuria. The more the patient is towards the red corner on the right side, more severe is the renal failure. And we have now drugs to reduce or halt, and in some cases even regress the progression of albuminuria. And that's where we reduce the all-cause mortality, the CV mortality, the ESRD and AKI when it happens. This is a very, very interesting slide. In 2001, in my MBBS Viva, I was asked about this renal and irbesartan diabetes nephropathy trial. Yes, so now you guessed my age correctly. It's 21 years post my MBBS. And what I'm going to show you now, that was the time I decided that I don't want to become a nephrologist, because this drug, I did not find it that promising. And exactly in 2015, some newer drugs started coming in the form of empagliflozin. And in 2017, Credence studied the Canvas study, which came as canagliflozin. And then now we have the DAPA-CKD trial, which came absolutely recently, which says that, yes, there is a gap. There was a 20-30 years of a gap between nephrology treatment, and we have a molecule, we have a drug, we have a treatment that we can offer to reduce regression, to reduce the progression of albuminuria, and to give good quality of life to our patients. So let's focus now on how we take this ahead from here. So somebody is writing medical calculator app for eGFR. Absolutely, that's the right answer. Kidney rog visheshagya, somebody is writing, but what is the translation of kidney? It's kidney rog visheshagya. Aapne to usko kidney ko to change hi nahi kiya hai. I'm still waiting. I'm giving you some times. So dialysis and finally think plan for renal transplant. And please write your name, because so that I announce who's really given the right answer. I'm still waiting. What is nephrology called in Hindi? Evidence for expanding the role of SGLT2 inhibitors to fill the vacuum in CKD management. How do we do this particular thing with re-prescribing or re-scripting the whole idea about the diabetes and the kidney disease? This is what is the abnormal thing which would happen, and this is where our ARB, that's your telmisartan, azilsartan, your olmesartan, losartan, irbesartan would come here. They add and act on this receptor. These are your ACE inhibitors, where you have ramipil and other kind of drugs, direct renin inhibition. But however, when you look at the afferent arteriole and vasoconstriction, we have SGLT2 inhibitors which act through the sodium hydrogen exchange, and of course with the glucosuria or the glycosuria, and that's where they actually promote these kind of an action to help the kidney patients. There are 8 more actions that it can do. The proposed renal pathway of SGLT2 inhibitors, the potential direct effect on CV, decreasing the pressure, intravascular volume, and decreasing overload. They decrease albuminuria. If you see here, they actually promote tissue oxygenation at the tubular level. They decrease inflammatory and fibrotic pathway. And of course, our most favorite, they decrease weight, NHbA1c, and decrease in BP. So I think when I took the session in IMA about diabetes and blood pressure a few years back, I did show you that study and the paper that we published regarding hypertension in diabetes that time. That time we all were enjoying the physical conference. So that brings us to the main section or the main talk for the day about when you look at heart failure, when you look at CKD, when you look at diabetes and CKD, how would you look into this particular trial? And let me tell you, DECLARE-TIMI was one of the largest and longest trial which came a few years back. And this trial is an addition to that DECLARE-TIMI. The pre-inclusion criteria were more than 18 years of age, EGFR of more than 25, which is again a big thing. They have macroalbuminuria. They were stable on tolerated doses, maximum doses of ACE-ARB for more than 4 weeks, and they were both with and without diabetes. So there were 68% of the patients with diabetes and nearly 38% of the patients, 28% or 32% of the patients without diabetes. Excluded were the renal and the type 1 diabetes patient. And that's how the study went up to nearly 2.5 years. It took approximately around 4,300 patients with them, and nearly 33% were females. And that's what I was saying, that only 70% or 68% had diabetes. So this study gave us prongs with both diabetes and kidney disease and non-diabetes and kidney disease from there. And look at this, what it was found, that nearly 49% reduction was there in sustained EGFR decline, in ASRD, in renal or CV death, which is a very, very important result. When you talk to the patient generally asks, doctor, isse fayda kya hoga? Fayda ye hoga. This is one of those important slides that we have to tell, that yes, isse kidney ka zindagi milega, heart ka zindagi milega if there is a heart failure with kidney disease, and isse aapka total prolonged zindagi ghatega. That brings me to your next question. Just by staying in urban area, how much life is compromised? How many years of life is lost? I'll give you a hint. Just by having a diabetes diagnosis, if you tell somebody that you got diabetes, I have 346 people as an audience over here. If I tell all the 346 people that agar aaj aapko bola ki aapko diabetes hai, 6 to 8 years of life reduces just with the diagnosis of diabetes. That's why we say that prevent diabetes, usko hone se roko, aur ho gaya to usko goli khane se bacho. My question to you is, this is in IMA Mumbai, South Mumbai. How much life expectancy is reduced by just staying in an urban area? I will look for the answers in the chat box in some time. A landmark trial, a landmark results, and a question which is so very important. I can see in video some people are smiling and trying to say answers to somebody. What was the exploratory composite outcome in this particular trial? There was a reduction of 34% of the relative risk reduction with either dialysis or transplantation or renal death. And the secondary outcome, CV death, was approximately 29%. All-cause mortality also, which was a secondary outcome, was approximately 31%. If you look at primary outcome in details, it's nearly for patients, those who did not have diabetes. Look at this, those 32% of the patient also had this. So even before you get diabetes, even if you have a problem like a kidney CKD issue, that also can be treated. And that is the reason this drug first from endocrine went to the cardio, because we had those heart trials, the nephro, and now we have the liver guys coming in between, and a lot of more indications which are expanding for the armamentarium of SGLT2 inhibitors. And look at this, our friend with diabetes and CKD, they've got 36% reduction in the primary outcome, which is an important landmark. And nowadays, we are having this molecule with half the strength as well as full strength available very, very widely. If you look at the etiology, nearly 86% had diabetes nephropathy in type 2 diabetes, and nearly around 14% of the people had some other reasons. So this trial, which showed that 70% of the people were benefited, but out of nephropathy in type 2 diabetes, 86%. So look at how many dialysis we will be saving, how many kidneys we will be saving, and how many years of life we are going to add to this particular answer. Okay. So I think somebody is really writing whatever is your name, 7.8 years for men and 5.5 for women. I think, is that a Googled answer? I don't know, but that's the right answer. Actually, somebody wrote 10 years. Actually, the answer is 8 years life is lost if you are an urban staying person. So that's quite an important reading. That's quite an important this thing. Now, my next question to you is, in how many people we find nephropathy in type 2 diabetes? Nephropathy as such, what would you do? I would wait for your answers again. And I'm trying to go forward. Yeah, yes. So that was the overall primary outcome. When you look at all the causes of kidney disease, and diabetic nephropathy actually stands very, very here, where dapagliflozin has fared very well over here with nearly 30 to 34% reduction. If you look at further exploring the causes of kidney disease, IgA nephropathy also, that's what I was saying, that the non-diabetic kidney disease also, there are huge amount of reduction with these diseases, and they would do, that's why, very well. If you look at this primary outcome again, overall, it gave us a very good result without heart disease and with heart disease also here. And if you look at secondary outcomes, everything was fared better, and it was in favor for dapagliflozin as a molecule and SGLT2 inhibitors as a class. What about diuretic use? Some people will have a question, but sir, that SGLT2 inhibitors cause diuresis. So what about patients, those who were with and without diuretics? Now look at the figures. Whether you used a diuretic or you did not use a diuretic, the reduction was 44% versus 45%, which is nearly the same. So your one tablet of dapagliflozin is doing the work for both. Of course, you have to select your patient accordingly so that there is much benefit in that aspect. Now, a lot of people are using mineralocorticoid receptor antagonist. That is one of the diuretics like your spironolactone, frenulone class of drugs. Again, here you look with diuretic MRA, it is 39%, and without that, it is 44%. And nearly it is the same amount of reduction. If you look at CKD at baseline in this particular study, nearly 86% had stage 2 to 3, and with stage 4 with or without diabetes, we had 36 versus 64%, which again says that they were quite having a bad disease. And if you look at the outcome according to CKD stage 1, 2, 3, 4, as we were talking about the G1, G2, G3, AB, and 4, 5, this is what says. And overall, if you see primary outcome and ESKD, DAPA again fared better for your patients, giving a good quality of life. If you look at eGFR decline, what does it show? For both CKD stage 2, 3, and 4, it showed important reduction and improvement in quality of life. Safety. Some people say you cannot use DAPA because it may cause amputation, but it was same for placebo. In fact, in this study, it was more for this particular stage 4 and more for here. So there is, that is ruled out. Definite or probable decay also, if the patient is euvolumic, nothing of this type shall happen. Fracture related event or major hypoglycemia was not there actually. So these are glucose friendly, and these are non-hypoglycemic or least hypoglycemia causing drug, even when you compare it with placebo in this 2 volume. Of course, you have to be careful with volume depletion, but however, with or without placebo also it was the same. So I think that's again an important aspect that we take it from there. Now, what about the declared TIMI, the mother or the grandfather of the dapagliflozin study, which was one of the longest and largest, which also showed about that there is a reduction with dapagliflozin 10 milligram in the declare, which had kind of a better baseline renal function than other studies. So if you look at people with very good amount of eGFR, still they had reduction. And if you look at the bad diseases, which I showed you in the second half of the talk of DAPA CKD, they also had stage 4 and 5, and it really helped them. And this is what was the 47% reduction. And the deterioration, concentrate on this burgundy box here, from normo to macroalbuminuria. Now, question to you, what is normoalbuminuria? What is that amount? Please type your answers. And what do you see here is that, yes, it is absolutely, it was worse for placebo, which means it was in favor of dapagliflozin. I'm going to change the slide. The slide may look similar, but the question here we would be asking is different. From macro to micro, or from micro to normo. So with this is, I'm trying to show you the regression of albuminuria. Here, this is that thing which is favoring DAPA. I'll take you to the one slide back. Here the heading is improvement in albuminuria. And here we spoke about deterioration in patients who were taking placebo. So drug not given, there is deterioration. Drug given, there is regression, and there is progression of a better quality of life related to kidney disease. So to summarize, if I have to combine the largest, longest trial of DECLARE with the DAPA CKD 4300, now we have a very clearly that this was only with type 2 diabetes, this was with and without. 85 was the eGFR, here it was 43. So quite severe disease was taken into consideration, and both primary endpoint did show a better outcome for this. So what about the latest guidelines now? Last few concluding slides. If your HbA1c is more than 7, please listen to this line carefully. If you have a patient with diabetes and kidney disease and HbA1c is more than 7, your patient needs to be on a SGLT2 inhibitor. Very clear about this. No questions asked that the diabetes is uncontrolled. Here the patient needs to be on SGLT2 inhibitor. If SGLT2 inhibitor is contraindicated, then GLP-1RA. For GLP-1RA, I'll request IMA to please let us have another talk. And if your patient is having type 2 diabetes, CKD, and HbA1c is less than 7, and the patient is already not on SGLT2, please give SGLT2. If with that, not on goal, then you add a GLP-1RA. A very, very important slide. This is a part of Eureka M and Diabesity Working Group from the ERA et al. Now, what about the American Society of Nephrology? Also talks the same, but look at something important. If your eGFR is more than 30, we give GLP-1RA. We'll give SGLT2 inhibitors first and then add on GLP-1RA. However, I want to update this particular line that now we have KDIGO guidelines also, which talk about that we can give SGLT2 inhibitors even if your eGFR is less than 20. This is the most updated information in diabetes and CKD that we are talking today. And if you're looking for too many metabolic benefits, then you have to look at individual session, individual patient, what you want to look at, and then take it from there. So I think with this, what we also need to understand is that the KDIGO guideline, which came in 2020, have been updated, and they talk about this as 20, and we take it from there. So I think I also want to suggest is, because it's 25 minutes I have spoken already, what I want to give a one-line message over here is, you will see a lot of population going on SGLT2 inhibitor. Important thing is you should know the contraindications where not to use this class of drug, because a huge amount of people are going to be on this. And those contraindications, to name a few, would be if patient has got kind of type 1 diabetes, if patient has got some kind of abscess, pus, or some infection in the body currently, or if the patient is pregnant or the patient is NBM. These are those important places where you would not want to use. However, these may change as we move ahead, because if you look at a DARE trial of dapagliflozin, patient, those who were in kind of sepsis with COVID, there was the first trial to use dapagliflozin with sepsis. So we don't know how it would change. And earlier we used to say that do not use in acute settings, but now we have trials talking about that we can use in acute heart failure SGLT2 inhibitors. So this is again one of the most updated information, that if you see a prescription which has been started very recently and the patient was unwell, it could have been for acute heart failure, wherein one of the treatment given is SGLT2 inhibitors. I think, ladies and gentlemen, with that amount, I would like to close the session here. And somebody has again written kidney rog visheshagya, but kidney ko kya bolta hai Hindi mein? I want that answer to come. And over to organizers for any questions. I'll be happy to answer. Thank you so much, IMA. Okay, so somebody is writing गुर्दे का doctor. No, it's not like that. So forensic वाले को हम मुर्दे का doctor नहीं बोलते हैं ना, तो उसका भी meaning है, there's a name. So the nephrologist is called as मूत्रपिंड विशेषज्ञ.
My.
It is Mutrapind. It is kidney and ureters together. So that's how they're called as. And if somebody can WhatsApp me, what is an endocrinologist call in Hindi, I'll give you a personal prize. My number is 9820-110699. You WhatsApp on this. 9820-110699. What is an endocrinologist called in Hindi? Over to the organizers again, and I can see Dr. Ahuja giving a very big smile over here. Thank you so much.
Thank you, doctor, for such a nice, excellent, and such an interesting lecture. Okay, anybody is wants to ask questions to Dr. Sheikh? Chat में है क्या? Nothing.
There's no question.
Yeah. Okay. Okay, thank you, Dr. Sheikh. Now, moving on to the next speaker, Dr. V.T. Shah. Dr. V.T. Shah is an interventional cardiologist attached to Kambala Hill, Breach Candy, Prince Ali Khan, Nanavati, Jupiter, and Surana Setia hospitals. He is attached to many corporate offices like SBI, RBI, Air India, MTNL, Mumbai Police as cardiologist. He did his graduation and post-graduation from Dr. V.M. Government Medical College, Solapur. He received fellowships of the Society for Cardiac Angiography and Interventions, USA. He has trained in Essen, Germany, and specialized in IVUS and FFR-guided coronary interventions. He has authored many chapters in cardiology textbooks and has several national and international publications to his credit. He is a very popular speaker and has been a guest speaker in many conferences, CME programs, national and international workshops. Today, he'll be speaking us on risk factor algorithm for ticagrelor 60. Over to Dr. V.T. Shah. Dr. V.T. Shah?
Yeah, let me try. Yeah, good morning, everybody, and thank you, madam, for that kind introduction. Let us see whether I can get connected and the slides. Can you see the slides now?
Yes, yes.
Yes, very good. So, good morning, everybody, and thanks for this opportunity. So, friends, today we are going to discuss some new strategy in the field of acute coronary syndrome. As you know, acute coronary syndrome consisting of unstable angina, ST elevation MI, non-ST elevation MI, previously known as non-QMI. All these three form together acute coronary syndrome. And in acute coronary syndrome, we know that the guidelines say that you should give dual antiplatelet agents. One is aspirin and the other, in previous days or older days, we used to say clopidogrel, more than 10 years back. So now the recommendation is to give a strong antiplatelet, second antiplatelet agent, which is known as P2Y12. So instead of clopidogrel, we nowadays use ticagrelor. Let us see whether I can change this pointer option. Okay, good. So we use ticagrelor. Okay, so now this can be used in a broad ACS patients of unstable angina and STEMI. Irrespective of whether the patient is going for medical management, angiography, angioplasty, or bypass. And irrespective whether somebody has given clopidogrel outside. So this drug, 90 milligram, 2 tablet stat as loading dose can be given with aspirin 300 milligram non-enteric formulation, right? Followed by 75 milligram in our country. And this is followed by 90 milligram twice a day. This is the standard of care in such patients. Now, you are supposed to give dual antiplatelet in acute coronary syndrome for 1 year at least. So by and large, we give aspirin tica for 1 year. And in some cases, if the bleeding risk is high, we may shorten this for 6 months. So now after 1 year, what? The thinking was that if you give such high dosage, maybe the bleeding would be more. So people started thinking of a new algorithm, whether we can reduce the dose of tica to 60 milligram BID and aspirin 75 milligram instead of 90 milligram, which we used to give. Now, for any recommendation or for any drug dosage to be put in practice, we require studies and trials, as you all know. So we had to take this dosage formulation and do a study. So let us see. Now, whenever we are treating a patient of ischemic heart disease with antiplatelet agents or blood thinners, as we call in common man's language, what are we looking at? We are looking at decreasing the ischemia, that is to avoid any MI or acute coronary syndrome relapse. That is what. But at the same time, if you use strong blood thinners, then the bleeding is high. So it is always a balance between ischemia and bleeding. So, 1 second. Yeah. So after an MI, we want to avoid a second MI or a second unstable angina. So you want to treat the ischemia and avoid any further recurrences. For that, you are giving him a dual antiplatelet agent along with all the other nitrates and vasodilators and things like that, and statins, of course. So now the question is, how long? How long will you give? So now if you see here that the risk actually lies up to 48 months. Okay, so if you see here that those who have ischemia even at baseline, the recurrence at 48 months is 18%. So 1 in 5 will get a recurrence once he has 1 MI, 1 unstable angina, 1 plasty, 1 CABG, and so on. So if he gets one of these, he stands 1 in 5. To reduce this risk, we are giving him dual antiplatelets. If he has only risk factors, it is 9%. And if he is stable without any ischemia, it is 12.2%. So this is how we quantify the risk, and this is according to the risk registry. And I was saying 1 in 5 who have events will have a subsequent MI, stroke or death within the next 3 years. So which means what? Which means that we should cover the risk at least till 3 years. Now, as I said, the question is, if you give dual antiplatelet for such a long time, 3 years, then what about bleeding? So this is in various countries, what is the risk profile? So basically between 15 to 21%. Now again, whenever we look at the risk profile, we also take into consideration the other risk factors which are there with the patient. One of the most important risk factor is diabetes. You all know if the patient has diabetes, then the second event is quite frequent and early also. The other is what we call as polyvascular disease, meaning thereby that polyvascular means involvement of multiple vessels, be it the coronaries, be it be the cerebral, the peripheral, the limb arteries, upper limb, lower limb, or the abdominal arteries. So this is known as polyvascular disease. So if you have polyvascular disease and diabetes both, as you see here, the recurrence rate is almost 50% over a period of 5 to 7 years, which is too high, which means 1 in 2 is going to get an event in the next 5 to 7 years. So if you have polyvascular disease and no diabetes, it is 30%. And if you have no polyvascular and no diabetes, then it is 17%. Nevertheless, as I said, 1 in 5 has the risk. So basically, in an ACS with pad and diabetes, you have the maximum event rate. So again, these are charts which show you that the event rates up to 30 months are high. Now, this is non-complex angioplasty. This is complex angioplasty. So if you see here, if I have done a complex angioplasty, then the chances of recurrence are high. So normally if you see that we also tend to continue antiplatelet, dual antiplatelet as we call, for at least 30 months or 3 years. And then if there is no event, we take the chance of reducing it to a single antiplatelet agent. Now, as I said, again, if you give for 3 years the full dose, then maybe the bleeding risk is high. Now, this was a study, as I said, that we ought to prove that 60 milligram twice a day, along with aspirin 75, is as effective in reducing the ischemic events and at the same time safe. So it should not happen that you reduce the ischemic events, but the bleeding rate is high. And at the same time, if the bleeding is less, the ischemia is more. We don't want that. So we want to have a balance between the two. And therefore, after some small studies, this study was designed, which is known as Pegasus TIMI 54, in which age more than 50 years of age, who had an MI prior to 1 to 3 years and had risk factors, as we were discussing earlier. Age more than 65, diabetes, second prior spontaneous MI, angiographic evidence of multivessel disease, coronary artery disease, or end stage or CKD. So these are all the risk factors for a second event to get. And of course, aspirin should be there on board. So if you have one of these criteria, then he would be included in this trial. And what was this study? As you see here, there were 3 arms in this study where you only give placebo 75 aspirin or 150, where you give Tika 60 twice a day plus aspirin 75, or you give Tika 90 twice a day plus aspirin 75. So either we give this combination or this combination. What is the idea? To see that the end of study, after 12 months, whether the ischemic events like CV death, MI or stroke are equal in both the groups and the bleeding is less in this group, right? Safety endpoint, TIMI defined major bleeding. This is what you want to see in this study. In the placebo arm, where there is only aspirin, you expect the ischemia to be more and the bleeding to be less. So this is how you do a study and try to prove your hypothesis that aspirin plus Tika 60 BID will be having the same ischemic benefits as 90 BID but less bleeding. So this is how the study was done. And as you see here, that there was, this is the Tika 60 milligram BID arm, and this is the 9.04 arm. And if you see here the primer, this is placebo, which means against aspirin. So the ischemia was less when you give aspirin plus Tika 60 milligram BID. So only aspirin is not sufficient when you have such kind of multiple risk factors. You ought to give him a second antiplatelet like Tika 60 BID. And if you see here that this is Tika 60 BID versus placebo, and in terms of composite endpoints, this was Tika is better, as you see here. MI and stroke were less. The deaths were not very significant, but the trend was towards lesser CV deaths in this Tika arm. So now the most important thing, we were talking about safety. So is it safe to give? We saw that the ischemic events are less than placebo. But what about safety? So if you see here, all these different types of TB, major bleeding, minor bleeding, fatal bleeding, intracranial hemorrhages, and fatal bleeding. So if you see all these, the trend is that Tika 60 BID, if you see here, that the bleeding events, the TB major bleeding events, and this against placebo arm was more, okay, in this. But the CV deaths was not significant, the intracranial hemorrhages were not significant, or fatal bleeds were not significant. TB minor bleeds were significantly higher and TB major bleeds were significantly higher, but there was no difference in fatal bleeds or intracranial. These were all outside the cranium, that is extracranial GI bleeds and so on. So of course, this is bound to be there when you take this, but what you are going to look at is the net events. So the net events, if it goes in favor of Tika 60 BID, then that has achieved a primary safety endpoint. Now, if you see here that switching from Tika 90 to Tika 60 at the 1 year juncture can be most beneficial. So the number of bleeds when you switch from 90 to 60 is less, and therefore we tend to nowadays, instead of giving 90 BID, we tend to switch to 60 BID after a period of 1 year. So as we say, the net clinical benefit, that means that what you do is you take the benefit in terms of CV death, MI stroke. Suppose if the number out of 100 benefit is 20 and the bleed is 5, so the net is 15. So the net benefit is 15. So that is how you look at. So, so the net clinical benefit is there in terms of 60 BID. So in Pegasus, who have had an MI at heightened risk, as we said, more than 65 years, diabetic, CKD, and so on, then these patients will benefit from giving Pegasus, from giving Tika 60 milligram BID for another year along with aspirin. Is the first prospective randomized controlled clinical trial appropriately powered to assess the benefit of long-term DAPT in patients with prior MI. And the study therefore suggests that prolonged antiplatelet with Tika low dose aspirin may represent a new strategy to reduce antithrombotic events in appropriately selective prior patients. So for ACC AHA, they have included this as class 2B level of evidence A. In ESC, they have said class 2B level of evidence B for Tika 60 BID. So therefore, what we do is that whenever you have patients, you classify them into what group they belong, how much is the bleeding risk, how much is the ischemic risk. There are certain scores to evaluate this. And after a plasty, after how complex was the plasty, how much is the ischemic burden, and depending upon that, we classify these patients and select these patients for Tika 60 milligram BID. Right. So these are the patients at high risk, as we said, recent MI, already on clopidogrel, multivessel disease, diabetes, peripheral vascular disease, CKD, and multiple MIs, recurrent MIs. So all these patients are going to benefit after the 1 year of aspirin and Tika 90 BID. They will benefit with aspirin and Tika 60 milligram BID. So as I said, step 1, assess the bleeding risk and exclude patients at high risk. So they should not have bleeding tendencies, known bleeding ulcers patient, or those who have a bleeding episode or the hemorrhagic stroke or subdural hematoma, GI bleed history, anemia. If the anemia is there less than 10 grams, we don't take these patients, correct the anemia, find out the cause, especially piles and fissures are very common. Patients don't give you the history of that, but if you ask leading questions, they will come out with the steps. Or else do stool-occult blood. That's the best way. For 3 days, you find out stool-occult blood and see whether the bleeding is coming from the upper GI. Then assess the number of risk factors. And if the high bleeding risk patients, you exclude them. Low bleeding risk patients, you include them and give them the benefit of this therapy. So this is in high bleeding risk group. Okay. So patients with any of these predictors of bleeding were defined as high. The other 81 persons are defined as low bleeding risk. And if you see here, if you take patients of low bleeding risk, then the bleeding is less than those taken on high bleeding risk. So 21% is the relative risk reduction or MACE in those with high risk factors. The relative benefit of Tika varied according to number of ischemic risk factors. The more the number of ischemic risk factors, the more is the benefit, with greater net benefit observed in patients with low bleeding risk and at least 2 ischemic risk factors. So amongst these ischemic risk factors, as I said earlier, if you have 2 risk factors and you are in low bleeding risk, this is the candidate for a Tika. So basically what I would say is, friends, that whenever you are giving antiplatelet agents, first look at how much is the risk of ischemia. As you all know that today even the role of aspirin in primary prevention is challenged. Why is it challenged? Because they say if the bleeding is more, then the number of events reduced due to MI and stroke, then there is no point in giving. So as I said, ischemia versus bleeding risk, safety concern, net clinical benefit should be in favor of the drug, which is not there for aspirin in primary prevention unless there is a very select population. Okay, so that similarly here we are looking at, we know that dual antiplatelet post ACS, post plastic, post CABG is required. But if the bleeding risk is high, can we take lower dosage? And that is what is proven in this trial, where low bleeding risk patients with multiple risk factors should be given the benefit of aspirin 75 and Tika 60 milligram BID. So conversely, patient not at high bleeding with at least 2 risks appear to derive statistically significant relative and absolute risk reductions. Absolute risk reductions in the primary endpoint of MACE 21%, CV death 34%, all-cause mortality 25%, and net clinical benefit 20%. So that is the benefit. So thank you very much for your patient listening. If there is any question, I'll be happy to answer that. Just a second. Let me first stop sharing. Yeah.
Thank you, Dr. Vitisha, for such a wonderful presentation. Any questions? There's no questions. Dr. Vitisha, you are on mute. Kindly unmute yourself.
Yeah, madam. Thank you. So, friends, I hope that you understood the concept of decreasing the bleeding risk and treating the ischemia risk.
Okay, sir. Thank you very much.
Thank you. Thank you very much.
So now I'll request our Assistant Secretary, Dr. Kashyap Dakshini, to give the vote of thanks.
Hi, friends. Good afternoon all. I would like to thank our speakers for today's webinar Dr. Ruchira Mishra, Dr. Altamash Sheikh, and Dr. VP Shah. I also thank our knowledge partners for the day, Sanofi India, AstraZeneca, and Newberg Diagnostics. I thank Mr. Deepen Mehta, Mr. Aditya Kuche, and Ms. Vaishali Tanpuri from DigiShield, who have given us support and the platform for this webinar and handle all the technical details at the same time. I thank Dr. Kajal Ahuja, Assistant Director, IMA CGP, Mumbai Sub-Faculty, for conducting this webinar in a smooth and efficient manner. A big thank you to Dr. Pragji Vaza for being MMC Observer for today's session. Last but not the least, I thank you all delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much, friends, and have a lovely Sunday. Thank you.
Thank you. Bye-bye. Stay safe. Take care.
Thank you, sir.
Thank you, Awad Sahib. Thank you for your last-minute link. Otherwise, it would not have been possible. Thank you very much.
Thank you.
Nice to see you.